Good morning and welcome to our monthly webcast. This is the broadcast studio at Mount Sinai Medical Center and this is session number 35. Welcome also to our Chinese viewers from mainland China. Ni hao, and welcome especially to the three major centers that have joined our network: the Peking University Hospital, Fuwai Hospital and Anjan Hospital. Welcome to all of you. Going to take you right away to the studios where we have an extremely challenging trifurcating left main case, and we need to get started almost immediately there with this technically demanding case. Good morning, Samin.
Good morning.
I've already introduced this as one of the more challenging cases.
Absolutely. I mean, it's a very trifurcation case, and we felt that this is problem we do encounter periodically, and we felt that we are going to show various technical tips how to deal with these cases. During our live symposium, we usually have at least one, if not more than one, preferably two cases of left main trifurcation, and of course we do at least 5-6 left unprotected left main. But trifurcation is one of the issue, and that is what will be. I'm going to highlight how to manage those particular kind of cases.
Samin, getting ready for your meeting also?
Yes, as you said, this our meeting is annual on 14th and 15th.
So as a result, the first pertinent announcement is that the next webcast is June 19th to enable your conference?
Yeah, that will be but again, we try not to change our third Tuesday the schedule, and this happens to be that third Tuesday will be after our symposium, so that during the symposium we give the flash drive of all our cases, so they will have 35 cases including this one, but not the next month. So they will not have 36 full 3 years, but definitely the participant in the symposium will get 35 1 hour teaching, some cases a little more than 1 hour, of the all cases since the inception of our complex coronary live cases, which we started back in July 2009.
Samin, very impressive. I'm seeing the list of the topics, the list of the co-directors. If somebody asked you today what are the 5 reasons somebody should attend your meeting, what would you say?
Absolutely, that's a great point. I would say that clearly that there are so many live conferences going on, and therefore you need to provide something unique in your meeting. And I would say that one interesting aspect of our meeting, and what people constantly give us the feedback, is the hands-on technical details, and not just show and tell that you have put 2 stents here. How you got to that 2-stent approach with the selection of the guide catheter, selection of the wires, and the various technical issues, really we elaborate. So the one most important is the technical aspects. Second, this time we actually have divided our sessions into a specific viewer's preference, so that on the agenda we have made it the left main, bifurcation, total occlusions, and so that people can select, and also structural heart disease, so people can select which session they are interested in. The third point will be lot of emphasis on the structural heart disease, so much so that we'll have all 3 kinds of percutaneous valve which are being used at present will be relayed, starting with the pulmonic valve, and then 2 of the tower valves, both Edward Sapien and core valve, that those will be relayed. And then the 4th point is very interesting, that people learn all the trials data, and so that I have changed the format of the meeting completely. That's no lectures, it is all debate. So entire sessions of the lectures here very brief. Those lectures are in form of the debate. So any interesting point, should you give Plavix for clopidogrel for 6 months, 1 year, 2 year, should you use a bare metal stent, DES, and so that clearly all are in form of a debate. And lastly, we continue to have a 2 hour, 1 hour each day session of showing the complex coronary cases and discuss various aspects of management of those patients and get a teaching of how to tackle various complications. So that those 5 really in nutshell, we'll put it together, and we actually have a very nice cases lined up, and of course we still have another 1 month to schedule those cases electively for our June symposium.
Samin, sounds a very nice format. What should be the purpose for a nurses or a technician to attend, and what about the fellows?
Yeah, no, I mean, clearly there is a lot of fellows teaching both on 14th, 15th. In addition, there is a fellows interventional board review. We keep it on 16th, which is Saturday. For nurse tech, there is a whole dedicated day. And there we basically talk about at their level, for the nurse technician's point of view, various devices and various techniques, what they do day to day, managing the patients, pre-procedure care, post-procedure care, and follow-up. And that actually is a very big hit, usually over the 200 plus registrant just for that particular day. So that it's become part of the regular theme, giving update on the nurse technician, cardiovascular technician in our area, and it has been also perceived very positively along with the rest of the symposium.
Wonderful, Samin. Good luck with your symposium, and I know we have our hands full today, but in the meantime, I'd like to introduce our Chinese viewers again. There is a Chinese simulcast, and on the screen, go to the Chinese translation, click on that, and you should be able to watch our program. Anu, tell us about this case.
Okay, this patient actually, we start with the case number, as you said, 35, and with the 21 with our heart.org. It's presented in early mid last month with progressive dyspnea on exertion and Canadian class 3. Had also palpitation, disease spell. He hasn't seen a physician for a long time. They did a ETT which was positive, and echo revealed moderate MR, moderate to severe AI with dilated ventricle, but preserved LV function. And these are insulin requiring diabetes and risk factors as shown here, and paroxysmal atrial fibrillation. He has been on warfarin for a long time, and he just could not tolerate aspirin, so that he was started on clopidogrel, beta blockers, and rest of the medical therapy shown here. Now he did have a cardiac cath on April 17th, and Anu will show that, but basically in a sense it showed 3 vessels with left main trifurcation disease with normal EF, mild MR, and 3+ AI. And basically at that time we offered him, as we do with the syntax score of 31, our heart team discussion took place with the surgeons, and so patient was offered CABG plus aortic valve replacement, but strongly, and we actually have seen in our Russian community here, we have one of our cardiologists who comes with the patient, stays with the patients during the procedure, and patient, they're not pro CABG unless it's a question of life and death. So the patient was recommended CABG and AVR, which should be done with the complexity which we'll show you, and after that discussion, patient declining, we went ahead and put a stent in the right coronary artery, and now patient is here for the left main trifurcation, and Anu will take us through the angiogram of this patient today.
So this is the groin shot. If you see here the first shot of the femoral artery, and then how the iliac, very tortuous, already you see what we call as curly Q iliac vessels. In this situation, what you need to do is, before you advance your wire, always bring the tip of your catheter behind. If not, you could just, since the tip of the catheter is touching the wall of the artery, you could cause a retrograde dissection and completely lose the vessel. So very important, you pull the catheter back, advance your wire, and this is a situation where you definitely need a long sheath. So all the iliac and aortic tortuosities are taken out, and this is his LV function. His EDP was high at the 35 range, with nitro came down to still 25, dilated, but LV function is still normal. This
Anu,
is his,
Anu, what about for a moment going to the left groin? Do you think no need for that?
I don't think
I
am
similar tortuosity. Also.
Okay, yeah. Chances are the same thing will be there. All right.
We usually don't move to the left side unless there's no way you can advance the catheter on the right side, because more often it's the same anatomy on both the sides. This is the RCA, anterior takeoff, could not engage with the regular JR catheter. You need AR2. So he had a mid RCA disease and was stented last time, which looks patent now. And this is what you see in his left main. Same when you have a despite a long sheath, he needed a JL5 for if it is diagnostic, in which case if you are selecting a guide, you need a longer guide, means either a 4-5 kind of a guide catheter, whether it is VL, FCL or even a FL guide. So, you have a tapering distal left main starting with the ostial LAD and ostial circ, and there is a big size hilateral, about 30% disease of the hilateral, but then this is the LAD. So, the proximal LAD starting from the ostium involves another moderate size diag, again with moderate disease. Ostium of the diag, moderate disease, further down some disease, but rest of the LAD is okay. Yeah. And this is the IVUS. If you can just show the IVUS, is significant disease of the entire LAD coming up to the left main.
Yeah. Show the IVUS pull back right from the beginning.
Yeah.
Fortunately, not too much calcification.
No calcium. Yeah.
So that makes our life a little easier.
Concentric plaque.
Yep. Yeah. We're starting from the mid LAD, and you see that very nice the non-calcific. And I say that the calcium. They say, well, IVUS is more diagnostic tool for calcium, but I can tell you based on the angiogram, we got our eyes very well trained that see which one is calcified or not. This one we look like very minimal to no calcium, and exactly what shows large part of atheroma. You can see the lumen almost abutting against the IVUS catheter despite such a large vessel, and then we'll come back to the ostial of the LAD and then distal left main.
Some arc of calcification there though.
But very, again, it will be less than 90%, so that I'm sure those all lesions do have some calcium, so that anything less than 90% is not an issue. And the whole point was that the level of the trifurcation, is there a disease of the ramus intermedius, because this is truly a trifurcation lesion. Actually, you could call it a quadrifurcation, largely because of the diagonal has little disease, but that's far away. So it's a classical trifurcation lesion. If we can just go back to the angiogram again, and this is where as we know that most of our the distal left main bifurcation is the bifurcation lesions are about 65-70%, and about 25% is in the ostium and about 10% in the body. So that's how basically happens. 25 ostium, 10% body, 65% distal bifurcation. Of that distal bifurcation, the studies have shown about 15% are trifurcation. Trifurcation basically means that each branch is more than 2.5 millimeters. So anything 2 millimeter and so the small ramus is probably more common. But if you're talking about a vessel which you need to intervene in case some issue occurs, 2.5 and so is in about the 15-20% of those bifurcation lesions. So this is a classical type of case which is not unusual. We encounter with those bifurcation, and that truly it's a distal left main trifurcation. Now with that note, I just wanted to show appropriateness, that very high appropriate criteria with the class 3 symptoms and 3 vessel disease. And we will start with our technical pearls with Anu, and going through the various issues, which part of that has been already, but quickly just go through them.
Once we know there is a left main bifurcation, trifurcation, I think 7 French is the minimum that you need to take, unless you know that you just want to stent across one vessel and completely avoid the second vessel, in which case you may think of 6 French, but it's always better if there's no peripheral vascular disease and we can go. Probably 7 is a minimum, or even you could go with 8 French. And I think I already mentioned, since there is aortic tortuosity, iliac tortuosity, long sheath, and get a guide so that we have a good guide support. So ostial lesion, same, try to have a non-traumatic guide. Usually FL guides are the best for the ostium, and distal, as long as we know there is no calcium, no tortuous circ or LAD takeoff, where we know negotiating the stent will not be a problem. Any kind of guide, whether it will be VL, FCL, EBU, any kind of guide should be okay. Here we had to take a VL 4.0 guide, for better support, and we were able to get it seated, and it's nice sitting coaxial to the in the left main. And then comes the same, knowing that there is no calcium, how are we going to do the plaque modification? I think atherotomy is very important, so we get a good stent expansion, especially of the ostia of both the LAD as well as circumflex. So here we will be doing a cutting balloon of both the branches, and wire selection, you could use any kind of your workhorse wire in either of these branches. No, it is not something. It's
Samin, a quick question which has come to us from the Philippines. Dr. Oliver Bolser, good day. Is this patient a candidate for TAVI after this PCI?
Well, actually, as you saw, that so far is still pure aortic regurgitation. There has not been the data on the pure AI. But prosthetic AI, yes, but the pure AI, if you go with the core valve, actually first 2 cases back in 2003 were done in India for AI, and they did not have a great result. So that the part of, if you think about the TAVI works, that your stent will anchor to the calcific valve. So that, right, I think there may be some designs later on that we'll work it out for the AI, but definitely not for the at present existing stents would not be. They will work for the prosthetic AI. Patient has a bioprosthetic valve now having degenerated, those cases yes, but not necessarily for the TAVI at present for the AI.
Samin, the reason you are not using either a balloon pump or Impella is because of the AI?
Yeah. Absolutely, yes. And same near normal LV function. In this case, if you really need a LV assist device, probably may need a tandem heart, which is a rare. We don't use that now for over 2 years. But Impella as well as balloon pump will not be favorable in this setting. And this case has a clearly very dilated ventricle with a 3 plus AI.
Samin, I bet you this is one of the questions which is going in the minds of the audience. There is a RCA lesion, trifurcating, quadrifurcating lesion. If this was your father, would you be doing this procedure?
Well, I would say very simple that we present the data to our patients. And this patient had a clear-cut presentation of the data, not in the cath lab. After the angiogram was taken out of the lab and had a discussion. So coming back to the point that my father, would I do? I would say recommendation 1, 2, and 3 will be cabbage AVR, and cabbage AVR. Now still, based on the personal belief, says no, my dad then will proceed exactly what we are doing now. Yes, it will not be my first, second, or third recommendation, but many times we do because of the patient's choices.
Excellent, and I'm sure, as you mentioned, there was an extensive review with the heart team.
Yep. Okay, now with that note, while Anu is trying to put our catheters there, because patient, these kind of cases you need to do a little fast with a high EDP and so, and I'll just quickly go, and Anu, meanwhile, what is your strategy now? Tell what you want to do.
I think we just wiring both LAD, we already are wired for the IVUS. We are just going to take a second wire to the circ cutting balloon of both the branches, which is circumflex and LAD. Cutting balloon for the circumflex and angiosculpt for the LAD, and then we'll use a 2-stent strategy. High lateral, knowing that there is no disease, goal would be that we would leave that vessel alone without even a wire in the high lateral. The question is, if there was disease, which we are talking more than 50% in the high lateral, how we would have approached it. I know there's a 3-stent strategy, but still, depending on which branch is larger and supplying more myocardium, then we make a decision where would you go with the 2-stent strategy. Do the 2 stents, and if the third branch has a significant pinch after that, you can still go through the barrel and dilate it if need be.
Anu, why did you think about choosing the angiosculpt for the LAD and the cutting balloon for the circ?
Cutting balloon, if you see there, significant circ disease, I think you definitely need a good, significant short lesion, where you need a good atherotomy, and if you see, the LAD is a longer lesion, so 10 millimeter flextome would be better to take care of the entire 30 millimeter lesion of the LAD.
No plaque modification planned for the distal left main?
I think the same. When we are doing LAD and circ, the part of the balloon, it will be covered. Yeah, we definitely will take care of the distal left main when we are doing both LAD and circ.
Sameen, please go ahead, educate us about the teaching tips here and what the fellow should be concentrating on.
Yeah, no, that's a great point. And as you know mentioned that clearly, just to come back and complete that, that where do we use? We have both available in our lab, the flextome as well as angiosculpt. That which one do we use where? It largely depends on few of the characteristics. Now, if there is a short ostial lesion, we go and it's not only mildly calcified, then we go with the flextome. But it's a long lesion, instant restenosis, heavy calcium, we know that you need to go to little high pressure, and therefore the flextome may not be, you cannot go beyond 10-12 atmosphere. Then we go with the with the angiosculpt, where you can go to 16 or 20 atmosphere if needed. So with that note, that is where our selection strategy, and that is what Anu has decided, that we use a 3O flextome, 6 millimeter for the ostial circ, and 3O 10 millimeter angiosculpt for the LAD. Purpose there is that we try to decrease the plaque shift, and data has shown that besides getting a better lumen, the cross-sectional area of the stent expansion, that you definitely by atherotomy you decrease the plaque shift, and here we want to decrease the plaque shift in the diagonal, we want to decrease the plaque shift in the ramus. Idea is we come out with a 2-stent strategy and don't need to deal with any of these vessels, diagonal or ramus will be our goal. Now with that point, if we can go back to our slides, talk about the left main bifurcation, trifurcation lesion, and second will be the DAPT in patient requiring long-term anticoagulation. So they're very important in this patient. Patient needs, as a paroxysmal atrial fibrillation, patient need long-term anticoagulation. So therefore, now you have put a stent, you have done a stent of the longest, particularly double stents and so, and you really want to take care of these cases with the dual antiplatelet therapy. Some people say, what if I just give warfarin long-term anticoagulation and don't give antiplatelet therapy, or just give antiplatelet therapy and don't give long-term anticoagulation? I'll show you the data. So therefore, this is a very evolving field where I would say that yes, there is a no clear-cut answer, but I'll give you our Mount Sinai protocol for that. Now basically, the trifurcation, as I mentioned, that's the basic, the taking care of all the 4 branches, and then you name it as like the Medina, and as you know, the trifurcation has a very high incidence of high syntax score. One trifurcation lesion could get you a 33 syntax score if you have involvement in all the vessels and there is some calcium. Now the question comes that this French word that menace a trois, the solution, should you take care of all the 3, put a 3 stents or so, and this actually have been done by few case reports, and that is the 2 reports I'll show you, that using a 3-stent approach you require a 9 French guiding catheter. This is the report of the 20 patients with the 2-stent thrombosis with a 10% thrombosis rate and very high TLR, and the second again the study of 27 patients with a high event rate in 1/3 of patient at follow-up of about 2.5 years. So therefore, overall message is very simple, that you decide that you don't need to take care of 3, you pre-dilate all the branches and stent 2 important branches, so that trifurcation should be converted to bifurcation as an operational and technical strategy. Very simple, straightforward message. Then you decide whether you want to use a SKS V stenting, T-stent or culotte, or short or mini crush is based on the angulation, and so SKS and V stent is the clear-cut advantage. It eliminates recrossing, eliminate your worried about the jailing the wire and so, and done with the quick the dilatation. And this is where if you put it, this is the approach based on the significant how bad is the circumflex and how big the left main, that if the circumflex is small, I think single across the circumflex stent going into the LAD is the preferred approach. Now once you get to the large and disease circumflex, that's where the issue comes. If you are not that large, the crush or culotte or T, but if they are both large segment of the LAD and circumflex, like this particular case, kissing stents are preferred. And now what we had done at Mount Sinai is going to show here, that at present at Mount Sinai we take these cases, we are talking about the distal left main bifurcation, only about half, 50 to 60% get single stent, about 40% get a kissing stent. Rarely will use a crush or T stenting. We by principle in our lab we do not use the culotte stenting. So that's where the division of various stent approach, and of course Excel trial will answer this question, that can in a moderately lesions like this case, because syntax score is 31, that could we get to as good as results as the coronary artery bypass surgery using the Zions prime the stent. Second is the DAPT in patient requiring long-term anticoagulation. As you know, there has been their recommendation, and they were updated back in 2009 with a focused update that use of warfarin in conjunction with aspirin and or clopidogrel is associated with an increased risk of bleeding and should be monitored closely. Clearly, it's a class 1B because these people, these patients do bleed quite a bit, so that you have to be very careful once you give a triple therapy. Now, second, this actually was the part of the new recommendation of class 1C back in January 2009 focused update, that if patient use warfarin, then clopidogrel and you need to have, because you have put a stent now, that both clopidogrel and aspirin should have a INR low around 2, not they say 2 to 2.5, but I have said 2, with a low dose aspirin 75 to 81 milligram and clopidogrel 75 milligram daily. Now you say that why you need this triple therapy, because that is what has been shown to give you the best results, yet it does cause higher bleeding. Now see this very simple answer. This is the study from multi-center from Europe, that patients who are atrial fibrillation undergoing stenting, you give anticoagulation or you don't give anticoagulation, you can see there that if you have no anticoagulation, that you have a significantly higher embolism and mortality. So therefore, clearly anticoagulation should be given to this patient with atrial fibrillation. Then second issue, clearly that associated with a higher MACE rate for the same purpose. The second issue comes that from the GRACE registry, that if you are taking warfarin and the antiplatelet therapy, that what are the data? Now very simple, that you have warfarin with a dual antiplatelet therapy, and secondly warfarin with a single antiplatelet therapy. You see that data very clear, that using a single antiplatelet therapy is associated with a higher embolism, stroke, and so very important that you need to use a dual antiplatelet therapy in this patient who require long-term anticoagulation, particularly with the atrial fibrillation. Clear-cut data. Second issue, that if you need to use a single for some region, therefore clearly I want to emphasize once again, the message should be very clear. You need a triple antiplatelet triple therapy, warfarin along with a dual antiplatelet therapy. Now, if for some region you want to use only a single antiplatelet therapy, whether should be aspirin or thienopyridine, again the data comes very important. The only published literature, 100+ patients, that if you have a choice, you should be thienopyridine, not aspirin. So very simple, that the patient should get triple therapy, and those, if some region gets single, it should be thienopyridine, particularly with a drug-eluting stent, compared to aspirin. Now, we actually have a very nice data from our center, because we on issue of that should you be giving the triple therapy daily, and we know that cause bleeding, that you give 81 milligram of aspirin, clopidogrel 75 milligram, or because of the long half-life of the clopidogrel, can you change it to every other day? And we call it a modified dual antiplatelet therapy at Mount Sinai. We started this protocol many years ago, back in 2006 actually. One of our very esteemed cardiologist, Dr. Jose Meller, is the one recommended, because he has been using this practice for a long time on his patients, but clearly with not clear-cut follow-up. So we started methodically and started following up those patients. We call it a modified dual antiplatelet therapy, that you give clopidogrel every other day. And you see here the follow-up of the patients, that clearly that giving every other day clopidogrel along with baby aspirin of 81 milligram has the least vascular complication and trend towards lower bleeding. So that in my opinion, without increasing stent thrombosis or ischemic event. So very important that maybe approach, although it's not a randomized, but these are the selection bias quite a bit. Now, then question comes, we have the new kid on the block, the newer antithrombotic agents. With many of these now, actually the 3 of the major trials have been approved. One have been reported. The most important, with the drug available, Dabigatran by Predexa in a RELY trial. If you go back to the data, while the Dabigatran was superior to warfarin in every category, whether it's a stroke, or it's a mortality and so, and lower bleeding, but there were 2 major issues. One, there were a higher incidence of myocardial infarction. Now, this is not the only drug. There was a drug earlier also which was used for the DVTs. They also had a higher incidence of myocardial infarction. But the first of this agent had a higher MI rate. And therefore, you need to think about that somehow the thrombin inhibition along with the factor 10A inhibition may promote platelet aggregation somehow, therefore higher MI rate. But also in the trial they have a lower GI bleeding. Now then we have the two other trials, which is the Rocket AF of rivaroxaban, and then Aristotle with the apixaban, which is the major landmark trial, particularly showing lower mortality. There was no increase in MI noted in both the trials. So therefore, what we have done at Mount Sinai, this approach of the long-term anticoagulation post-DES and use of antiplatelet therapy. One, that if patient is on warfarin, keep INR around 2, use aspirin 81 milligram and clopidogrel 75 milligram daily, and if prasugrel is needed for clinical region, then no aspirin and only prasugrel 5 milligram daily. Because what we also learned that prasugrel cause more bleeding. So that if we use with the warfarin, we use it only 5 milligram dose. And in this group, we actually will give clopidogrel 75 milligram every other day. Now, if patient has bleeding issue and you don't want to give any agent, only single antiplatelet therapy, then clearly that single antiplatelet therapy of clopidogrel will be preferred. Now, second, but if you are with a dabigatran, the aspirin 81 milligram along with clopidogrel 75 milligram daily, or if you are using prasugrel 5 milligram daily, due to higher MI rates in the RELY trial. Although it was not seen with apixaban or rivaroxaban, and hence clopidogrel may be recommended every other day once available as with warfarin. So that clearly what we have been using, that with the dabigatran patients, we use clopidogrel every day. In a warfarin patient, we use clopidogrel every other day. Now, that's why I have left it as a recommendation that could be used daily or every other day, but data are fully supportive that you need to give all three therapy for these patients despite risk of bleeding. Now, with that note, we come back to Anu, that she has done little atherotomy work already in the case.
Samin, excellent review. A quick clarification. The first paper you showed by Nick Shamus, that demonstrates a TLR of 12%, but in the same paper he divides it further into type A and type B, with the type A, which is your case today, having a TLR of in the 30s to the 40 range.
Yeah. Yep, absolutely. I mean, clearly that more lesion will be that even with the 12, there will be a higher incidence of the TLR if you truly use the 3-stent approach.
Just to put you on the spot before we go to Anu, how many stents do you think you'll end up using here?
2, no question. And knowing that this trifurcation,
not more than 2?
No more than 2. This, I would say, my personal experience of treating maybe 100 plus of this trifurcation lesions over the years, that will come out with the 2. Now, in this particular case, because of the long stent length for the LED, if we would have only 28 millimeter, then I would have said the 3 stents with additional stent in the mid LED. But here, our goal will be stent from the distal left main going into the proximal to mid LED, one long stent, and then another stent from the distal left main going into the proximal circumflex.
So you're going to do exactly what you had shown in your slide, converting the trifurcation into a bifurcation stenting technique.
Absolutely.
Anu, tell us what you've been doing, please.
Yeah, so we have a run-through wire in the LED and a fielder in the circumflex. This was a 3O angiosculpt balloon. If you see there in the LED, we just made sure that we had to pre-dilate the entire lesion, and this is exactly what mentioned was that if you have a distal left main, you make sure when you're doing the ostial LED, the balloon will cover the distal left main and really go high pressure between 14-16 atmospheres, so that you get a good expansion of that area. And this would be the how this is the LED after pre-dilatation.
Yep.
You see that is a good expansion. Suppose we know that the distal left main ostial LED, there was no good expansion, then either you have to go with a bigger balloon, or you may have to change to non-compliant and go high pressure, almost 20-22 atmospheres, to make sure that expansion has happened. Usually it does not happen if it is in this kind of situation where we know there was no calcium.
And also a good illustration there, if you can go back one view there, no plaque shifting there into the circumflex.
Exactly.
So far, yes.
no plaque shifting into the high lateral or circumflex.
Yep.
Now for the circ, knowing that it was a tighter disease, we did go with the flextome. Again, we
Some
took a
people would argue why not just use
Same
the
balloon.
same angiosculpt
Yeah,
and turn it around.
exactly, no problem. We could do the same thing. Now here always the issue is since always circ posterior and more angulated, usually your cutting balloon, whether it be flextome or whether it be angiosculpt, usually does not make a turn into the circumflex. We always see that. In that situation, what you do is go to the distal left main, and even if your nose, the tip of the balloon is in the ostial circ, go ahead, dilate. So you are causing some kind of atherotomy. And second time, same, you get your guide closer, you can ask the patient, take a deep breath and try to keep going forward, few millimeters every time, and finally able to get the flextome, make the complete turn and get a good expansion. This was at 10 atmospheres 3/0 of the circumflex. But that technique is very important, which I just mentioned. If it does not make a complete turn, even if the nose of the balloon is at the ostium, dilate, then next time you can pull the balloon back completely into the guide, go back every time you are going forward millimeter by millimeter. So that is how you can get this device into the circumflex. Many times you also see that situation if you are doing a diagonal ostial intervention.
Anu, with such significant AI and bobbing of the catheter back and forth, anything you have to do to steady the placement of the stents?
We'll see now. I think as long as you know, once you place a stent, your guide has to be coaxial in the mid portion of the left main, so that we know we will have a good placement of the guide. But so far, I think even to get this flextome down the circumflex, we did not have a lot of trouble.
Anu, how did the patient tolerate the atherotomy of the LAD and the circumflex?
No change in blood pressure or no EKG changes.
He's just a little restless lying down.
Yeah.
And we actually, because of the high EDP, and so Vicky already had this patient had a Foley catheter, knowing that otherwise they will have to get a urinal, they may not make the urine, and so it's 28 now. And therefore, now this is the one I wanted to show, that clearly that people, although there are no clear-cut data to say, well, that you should do can use a high pressure balloon only, and so that once you use the atherotomy techniques, look at this one, almost no plaque shift into that ramus.
Right.
And no plaque shift into that LAD. So this is where the advantage of comes, atherotomy, so the debulking of the lesion without causing the plaque shift, which have been shown by atherotomy, or we actually have published in our earlier data with the rotation atherectomy.
Same thing, I think while we did, once we finish atherotomy of LAD and circumflex, suppose there was plaque shift or change in the ostium of the high lateral, we may have to change our plan, that we may have to wire and predilate the high lateral before we do the stent. But so far, since the high lateral looks good, I think as decided, we are not going to wire the high lateral. In situation like this, always go place your stent in the more angulated vessel. In this case, it is the circumflex. So we have taken a 3028 Zions into the circumflex, which is right now placed there, and then we were going with the 3538 into the LAD.
My instinct was that you would probably use the 3.5 for the circumflex also, but because of SKS, is that the reason you want to be sure that the carina is not overexpanded?
Yeah.
I
mean, I think the 3.5 maybe
looks a little big,
bigger.
and
Right.
you will see it here. This 3.0 will have a very good residual lumen of minus 5-10%, because circ always look quite the bigger than what they appear to be. Go.
And the same thing, the stent in the circ can go a little distal till you place your LAD stent, and once that is done, you pull back your circumflex. Now you have a V, both of them you get back, so you do a short carina.
Excellent demonstration there, Samin. I think very important here at this moment to discuss about your choice of DES.
I mean, clearly that...
Now, this is what you wanted to know, how with the bobbing of the guide, how you are going to place it. This is the way, if you see that, there is no bobbing right now. Everything
you
looks good. We just go ahead.
Slightly deep-throated
Yeah.
and very nice. You need to come back a little bit on the circ stent to get it exactly.
No, I think we are
It's
good.
okay?
Yeah.
All right.
We just go ahead now.
You'll illustrate to us the steps of your SKS.
Yeah. So I'm just holding both.
You think maybe a slightly longer DES could have covered that
No, I think
LED?
you're well covered. Yeah.
Okay.
But it's a 38.
Wait.
Yeah. So now we need to bring.
Okay. Better overlap there.
Go ahead, place it. So rather than moving.
Okay. Now.
It's good. It's good.
Good.
Vicky?
Good. Go on. Okay. We are going now. Nice overlap. Again, all these had to be a second generation stents. Both 10 atmosphere. Now question comes is that can you be using simultaneous inflation and deflation? Then individually we go to a higher pressure to just deploy the stent
Now his starting blood pressure was 100, so we are already giving neosinephrine to make his blood pressure above 110. Circ has not expanded, right?
Yeah, we can post dilate later. Go. Yeah, 14.
Okay, okay.
So how high have you gone there?
4. Both individually 14, and we'll go with a 10 atmosphere once again.
Simultaneous.
But let it breathe now, because the
Because
final issue that has to be that this is the where catastrophe can occur. So now Vicky has to give little neosinephrine, keep the blood pressure up, and then we will wait few seconds. When the pressure starts touching 100, we are going to go up. I would say that let the artery breathe a little bit right now.
Well, also in the breathing process, I noticed Anu did another very nice thing, pull the guide back.
Yeah.
Exactly. In the very
Because,
important.
you have to let
Yep.
perfusion for this
Yeah,
time.
those simultaneous inflation and simultaneous deflation of 12 atmosphere for each, and with good. Double negative. Now many people actually use a diluted dye and so, but my only problem is many times with a diluted dye, you don't see the stent fully expanded or not. So that we usually use this, but use the neosinephrine to increase the blood pressure and so. Yeah.
Well, the pressure looks to be quite all right.
Yes.
How much neo was given?
The 400.
Okay.
Yep.
He definitely has EKG
Guides
changes
because
also. Yeah.
And this is the most important point which everybody talking about, the longitudinal foreshortening and so, and I think is related to, in my opinion, the guide touching these cobalt chromium and the platinum chromium stents, and it happens with all of them, and it just basically is that the negative.
Nothing is negative.
Yeah. Take one by one.
Yeah, I will. Wires
Okay.
are getting tangled.
Yeah, that was very important that you're good. Yeah. And then second. Okay. You see the guide is out. Very important in these cases, whether ostial left main, ostial LED. We show a little diagram.
No, you can take a picture.
Huh?
Take a picture.
Looks wonderful. No plaque shifting.
See,
Except
so
the
this is
ostial-
other thing also. In the 7 French, you have 2 deflated, the stent delivery system. You can still take a nice picture to have an idea how the vessel is without taking the balloon out.
Probably
of the
need
guide.
a little more post expansion in the circumflex.
Circumflex. Yeah.
Exactly. And this is what, when we were going with the last inflation, I pointed out, see that the carina at the level of the circumflex was not fully expanded.
Are you happy with the length of the carina you've created?
Yeah,
or
very,
could it have
very
been,
small.
Right.
That's
Could
exactly
it have been made it
5
even
millimeter
shorter?
and so.
Right. Okay.
And you needed to cover because the distal, and look at the very nice step up and so.
Why is he having so much EKG changes? What size you
And
have?
yeah, and you can see that now clearly that the ostial of the ramus, we can play again. That ostial of the ramus is completely fine. They're both 3.5, right? Huh?
Check the dial.
Yeah. And the question he does have some slight lateral T wave changes. So we are going to go to the epicranial view to see that the diagonal, if anything involved in the diagonal, and so.
that the origin could have been a little impacted with the LAD stent maybe,
Yes.
but
Yes. Okay. Yeah, the diagonal is gone.
That's right.
Yeah.
Anu,
this is-
so you were able to pick that up because you saw some
lateral,
EKG
yeah.
changes?
Yes.
Bag, yeah.
Okay.
Yeah,
So-
let's clearly dilate what we are going to do now, and this is very unusual that these kind of stents will give rise to a closure of the side branch, but does happen because of large amount of plaque shift. It did not happen at the time of the atherectomy. It did happen after the stent placement, but we'll use a fielder wire after we dilate this carina, and then good. Let's go to other one.
Get us
And-
another fielder.
Yeah, another fielder and 2.5
No, 2.
2
2 or 12.
212 apex.
Samin, is this a situation where you would probably have used before, or would you consider using a 2B3A?
Yeah, in this particular case, although he had this fibrillation, he had no stroke, no other bleeding episode, except that he just does not like the aspirin gave rise to a stomach upset. Let's go. Yeah, and so that he has been only on clopidogrel and warfarin since his stent placement. Yeah.
Don't get green.
No, but even intra-procedurally, would you use a 2B3A?
Probably, I mean, therefore, this
Down.
is the kind of case you definitely want to use 2B3A because that has been shown to decrease the side branch closure.
Right.
And here, I would say first thing we'll do, we'll try to wire that diagonal and try to retrieve it. If we can open it, fine. If we cannot open, and then only I will go with this, with the 2B, the 3A in this particular case.
Anu, it's been monotherapy with bivalirudin?
Yeah. We had to give a bolus because with the just full bolus and the drip. Sir, is what?
The
Good.
circumflex looks
Very
excellent
good.
there
It's
now.
very
And
good.
so also the ramus.
I think
mean, look at this.
take out the wire
where
of the circ.
Yeah.
We'll take out the circ wire.
Yeah, circ wire. And basically, we thought that we will concentrated more on the ramus, and it turns out to be the problem occurred in the diagonal. Yeah. Now see this, and this was the diagonal here. It's a good sized diagonal, and there was just a very little disease at the ostium. In case when there is some disease, I have very low threshold of dilating it before we stent. But in this particular case, I didn't feel the need for it, but turns out to be now. Also, what we should do now, that could be some plaque shift, some slow flow, so that opening the ostium by giving thrombus at the ostium, give a little verapamil, and that's what I'm going to do now.
Pressure may drop, so just be careful.
Okay. Now
Go to
let's-
the same view. Wait,
Uh-huh.
you don't see. So now in this situation where you don't see a side branch, total flush occlusion, what you need to do is go to the view where you saw the diagonal, which was here.
Well, either that or areocranial, maybe a little.
Yeah, areocranial, the first
Yeah.
picture where we
Yeah,
had.
right.
See
This
here?
view should be
Yeah,
perfect.
go to the same view,
Yeah.
put it road map, so that is the only way you'll get in. Huh?
We actually
Go to
went-
the same view.
RAO 25,
1637.
1637. Okay. Good.
Okay, somewhere.
Okay. I'm taking a picture first.
Samin, there's a very complimenting and nice email coming from Dr. Ian Herbert. Can't make it out at the moment where it is coming from, but we'll try to track that down. I'm going to read it for you. Good morning, doctors. I've been an avid follower of your program. It had a huge impact in my training and would guide me in my private practice. Just have one request though, and it's a wonderful suggestion. Can you show in a small window the hemodynamics during the modification of the trifurcation lesions, especially during balloon inflations?
Okay.
Again, great job to your team and more power to you all.
Okay. So I think
I
that
think
is
his-
for our audio-visual crew.
Right,
that when we are
his-
doing this complex case, to show the hands.
Right.
And maybe another screen for the hemodynamics. You always should be pointing onto the hemodynamics screen.
Excellent recommendation, Ian, and we'll try to show it here as well as in future programs.
Get
Anu needs a little more shape to the wire, or that should be okay.
I get a whisper wire also. The whisper actually you have seen
Right.
works quite well in
Very
these
nicely, yes.
kind of situation. You need to have a balloon support right now. Yeah, it's a very short area proximally, so that we may need to go even with a fine cross, so that if you need to change the vessel shape and size, and clearly the patient is a little restless.
That is not helping us.
Yeah. So why don't we go with the fine cross? That will be better.
It's just about in those struts right there.
Good.
There
You
we
got
go.
it.
Well, that curve it made accentuated your. All right.
Sometimes patient movements help.
Yeah, and the
Patient-directed.
guiding catheter bobbing through, you know.
Yeah.
Yeah.
No, guiding catheter bobbing, no, patient movement. You know why we pay so much attention to deep breath.
Absolutely. Samin, we need to go back to the discussion about your choice of DES for left main and even for bifurcating and trifurcating lesions.
Okay, now one other point I wanted to make. Since we have a carina, very important, I don't know if you had seen that, I had to go to the caudal view to make sure that the wire has gone in the right, this second field that is going in the LAD has gone in the right barrel. So for that, I had to go to the caudal view, make sure that we are in the right barrel, and then you go to the cranial view to get into the diagonal.
To our viewers, I need to also tell them we've made some enhancements in the methodology of how we are using Twitter. Please Twitter us at ccclivecases.org. And of course,
Now this is a 2 or 12 balloon, and if you see that I did not have any resistance getting from the left main into the LAD. If there was resistance, you do not push. If there is resistance, that means your wire has gone through the stent struts or gone through the multiple holes in the carina, so you pull back and rewire it.
Anu, it looked a bigger vessel than a 2.0. Why
Yeah, but we had to just get a 2.0 just to make sure that we go through the right part. Many times 2.5, even 2.5 would not go. So now we will go to a 2.5.
This is also a recommendation of Dr. Ian Herbert. Here is the window for you with the hemodynamics.
Yep.
No, that thing is not.
Viewers interested in registering for the annual 15th course, please go to cccsymposium.org or click the link below to get connected to the registration site, and you can also avail of the pre-conference discount. Significant improvement in the hemodynamics there?
Yep, and we are showing it there, absolutely. And actually EKG, you remember that little lateral ST depression, that all has gone now, and the same. In this particular case, that should you still use a 2B3A? I think again, I have very low threshold, but these kind of patients do bleed with the triple therapy.
Patient moved a lot.
Yeah.
It's falling off the table. That's the problem. Look.
Push the patient. Now, even patient got a little restless with the diagonal closure, but now everything seems to be okay.
Well,
On this side.
I think both of you need to be complimented on being very observant, quickly noticing the diagonal and taking care of it. Just highlights the importance of being vigilant in cases such as these.
What?
So we're going to take a picture now, and then we'll dilate with a 2.5 in that ostial, and then we already have a 3.5 balloon for the LAD, little kissing balloon dilatation, and we will reach to the lateral. Now, as you know, that at least for the dedicated bifurcation stent at present, 275. This is the 275.
For what?
For the diagonal.
No,
NC track.
Too big.
Okay.
Anu, you're not
Give me a
going to,
2.12.
there was also a lesion a little more distally on the diagonal. You're going to leave that alone?
that
That
will
was
be
plan
alone.
is to leave it alone. Yeah,
Okay.
we discussed that. Moderate lesion mid, because otherwise that will require wire came back. That will require putting another stent in there.
Yeah.
And same, as you mentioned, that how many stents you are going to do. If
That
we can,
looks a
do we
severe
want to
lesion
leave it
there
there?
if you take a look.
Yeah, but that will ask for another stent.
Yeah.
I think knowing that this guy cannot take dual antiplatelet therapy, this old age, We should not be putting, I think,
Or you want to
multiple
just leave it
stents.
there
Yeah,
right now.
I think so. Now
Yeah.
the vessel is open. Patient has, settled down.
And my
only-
feeling, and now these kind of complex cases will bring back for a long term, for a 6-month, 4 to 6 month angiogram, and at that time you can take care of the any area which is remaining. My personal feeling is vessel has been opened, blood pressure is good, ST segment has disappeared. Why to make it more complicated case than it's
Yeah.
as such?
Do you
Because
want to kiss him or
no,
dilate
just
that?
a moderate, we'll open the ostium, they've not been deformed, and we can come back to our last take-home message. That is basically issue are that two of them, which we talked today, the trifurcation, PCI, and just coming back to that, we do have a dedicated bifurcation stent actually available out of US. One of them is XS Plus, which works very well for the left main, because it's a self-expanding. Self-expanding stent, and so but again, the required additional stent placement is the biolimuscle coated stent. And then, of course, in the United States, we are having a Triton bifurcation trial. Does it include left main also, Triton?
No.
Or exclude? That exclude the left main, and that's a bare metal stent dedicated with a 3-zone. That there is a zone to go to the side branch, zone with a transition from side branch to main vessel, and very thin stent layer in the main vessel. So that that's a Triton bifurcation stent. And those trials ongoing. There is no DES trial in United States. Of course, some of them have been started outside. So coming back to a conclusion, that published data support left main trifurcation to be treated with 2, not 3 stents approach. These patients should be closely followed, preferably with a follow-up cath in 4 to 6 months to detect any restenosis. That is what we are going to do for this case. And that time, it need additional stent, as you said. Keep the 3rd stent for the future, for the diagonal at that time. Second, patient requiring long-term anticoagulation post-stenting should receive conventional low-dose aspirin or modified DAPT, which is alternate day clopidogrel. These patients should be monitored very closely for bleeding and vascular complication, and preferably, as mentioned here, try to avoid 2B3A, because that is going to, unless there is absolute indication, and I would say from my point of view, go back to the angiogram, with the last picture which Anu has just taken, there is no absolute indication. Show the last picture, please. Yeah, and this is the last picture here.
Looks excellent, absolutely outstanding. No need to go back with the follow-up IVUS. Results look excellent.
Yeah, absolutely.
Samin, how are you planning to tackle the patient's aortic valve disease?
Yeah, well, I mean, knowing that they have been, based on the cavity dilatation issues and so, patient will be monitored by the non-invasive parameters and LV function. LV function so far has been normal, and the patient will go through the same, the indication of AI will occur when the cavity becomes those 5.5 and 6.5 respectively, and diastolic and end systolic dimensions. So that, or for occurrence of any clinical symptoms. We did a right heart cath last time also. Right heart cath was completely normal, but patient did have a high EDP and wedge pressure, but that was all related to the aortic regurgitation.
Samin, I've been also passed a note to inform viewers to come back on May 23rd for your peripheral intervention live cases with Dr. Prakash Krishnan. Give us an update. How is that coming along?
Yeah, well, actually, this is just a start, and we are trying to duplicate exactly what is being done for our coronary webcast, and with the improvement taking place every month, and this will be the 5th of its series. And I would say I'm very happy, pleased at this early part of the this webcast, and but they continue to make changes according to like ours and enrich the material with the presenting the latest data.
Anu, excellent case. What is your take-home final message for this case?
I think in this case we have, I mean, as planned, we knew that this is if you had to change the plan, would have been in the middle, that if bilateral needed something, or the diag is paying very important, that be vigilant with respect to the patient when they become restless, that you have your plan and keep doing the case quicker, so that in these situations the patient can actually, if you take longer than what you think expected, that's the time they can go into heart failure requiring intubation and all these things. And just to give you a point, this kind of complex cases we do every day. I have my fellow here, Gautam Reddy, who is graduating in a month right now. So these
Anu,
cases are done with the fellow.
What do you tell Gautam now that he's finishing? Should he be doing this kind of a case when he starts practice?
I would say in the beginning that they have to, as long as, the very important, we teach them that right now the appropriate criteria is the most important, that if appropriate, that they should start doing these cases in the early part of their, attendingship. You can start doing simple cases. This is a distal left main. If he has good support, they go ahead, do these cases, and almost all fellows who train from here go ahead, keep doing unprotected left main bifurcation, and more important is, I think, rotational atherectomy. That is what they take from this particular training place. When they go, they join a big group. They are the only people who do the most complex cases in the group, so much so the group starts referring the complex cases to them.
Excellent, and I am sure Gautam has been trained adequately in both transradial and transfemoral.
Yes.
Dallas, are you comfortable with the radial?
Yes. What?
Let's hear it from. Yeah, because radial now, because few of the attendings are very selected with or do all the radials possible, and basically overall 13%. Again, 13% is a very big number. They will do total 800 cases. 13%. Getting over 150 cases and so of radial interventions really goes a long way to develop their confidence.
Because if we take absolute numbers, we get really good training in terms of the radial approach as well as the interventions that we do. Even though, as Dr. Sharma was saying, it's only 15%, but the absolute number is a lot compared to other programs.
Gautam, what would be your strategy as you go in practice? Would you be using transradial as to the patient preference, or would you prefer it for certain substrates such as STEMI?
No, initially, I would just use transradial for most of my diagnostic, to get comfortable with the patient as well as the system. And once I know the system well, then I'll be try to use as much as I can for transradial, and I'll reserve the STEMI for later on once the system as well as the patients get comfortable with what I'm doing.
Excellent. Samin, final words from you?
That's it. The next month will be our with the heart.org relation, the 22 cases, and all have been done well as part of this shown today. And we just keep wishing that more and more questions come across our side, and we really make an impact and difference. But anywhere go. Last month I was in Cochin in our India Society meeting,
yes.
And so many cardiologists came to me, and they said that how they have been using this educational tool as a group, so that even if the number I gave that Ricardo provides us, that 5,000 and so, to me that definitely is at least 2 to 3 times more, because not everybody is opening the individual computer. Anywhere from 2 to 10 people are sitting in front of one laptop or desktop, so that the real people who are watching it much more than we are getting as a web hit.
Well, we are also not still factoring in the numbers coming from China.
Yeah. Yep.
Samin, good luck to you with your symposium. We'll see you on June 19th for the next webcast. Till then, good luck, and I hope you have enjoyed the case today.